Dear students, so good morning one and all. In the last class, we have discussed regarding what is epilepsy, what are the different types of epilepsy, and what were the causes that caused epilepsy, and what is the pathophysiology of epilepsy. And also, we have seen these clinical findings and laboratory parameters, what we'll be using for detecting the type of this epilepsy. So now today in this class, we'll be discussing regarding the treatment of epilepsy. So, what is before going to treatment, the entire pharmacological treatment of epilepsy? So, first we have to know what was the non-pharmacological treatment and what are the goals of treatment. So, that things we must know. So, we'll be starting with that. Yes. So, the topic we are going to discuss is treatment of epilepsy. And first, before going to the treatment, first we have to know what were the goals of treatment. So first and foremost thing of goal is of in any disease we have to reduce the symptoms of that is causing in this disease. So first we have to reduce or control the frequency of seizures. So we have to reduce the frequency of seizures and also we have to reduce the severity of seizures. And also we have to minimize any complications that occurs due to these seizures, allowing the patient to live life as normal as possible. That means, so when these conditions were decreased, then the patient will be living her life happily, right? So its main goal is to reduce the severity and frequency of seizures and to minimize the side effects and also ensure compliance, that is medication compliance. That means they should take medication regularly. Why? Because the anti-epileptic drug should be taken for a longer duration. So it is our goal to maintain the compliance, that is medication compliance should also be checked carefully. And then complete suppression of seizures. So first is to reduce the frequency of seizures and the second is complete suppression of seizures. That means the patient should be seizure free for at least 2 to 3 years. And also must be balanced against tolerability of side effects. That means for treating this epilepsy, we'll be giving this anti-epileptic drugs, right? So not only ensuring seizure-free period, but also after using all these anti-epileptic drugs, we have to make sure that the side effects were less. So because of this medication, the side effects will be there. That also should be controlled. That also should be in control. That should be also less. That side effects should also be less. And the patient should be involved in defining the balance. That means he should be able to balance between the medication compliance and also the side effects that occur due to use of these anti-epileptic medications. Okay, so he should maintain the balance between these two. And then side effects and comorbidities. Comorbidities is nothing but any disease which is existing coexistence. That means which is two diseases at the same time parallelly. If it is there, then we call it as comorbidities or comorbid conditions. So the patients who are having this epilepsy, they also have this anxiety or depression or sometimes both, that is bipolar disorder. As all these CNS diseases, they will be having so many comorbid conditions. So and also social issues like driving. So you should be very careful while driving. Why? Because if he gets any seizure like activity when he is driving, it causes life threatening condition because he may get into an accident. And job and security relationships, because of this seizures like activity, and also at the same time he may be having his anxiety and depression. So because of that there will be some clashes in their personal life too. So that also should be maintained properly. And social stigma, that means they'll feel like as they're having that disease, they'll be feeling alone, but they'll not mingle with others because of this depressive kind of condition. So they'll not mix with all the people. So that also that also will be there. So all these have an impact on this quality of life. So we have to reduce these disturbances and we have to maintain these issues and we have to correct all these issues. So these are the main goals of treatment. Okay. Now moving on to second slide, that is non-pharmacological treatment. So for every diseases, there is some non-pharmacological treatment and pharmacological treatment. Non-pharmacological treatment is nothing but using some preventive measures or taking some taking some food dietary changes in order to maintain the disease. This cannot cure the disease, but this will help in preventing further progress of the disease. So it includes, apart from taking medications, it includes first is surgery. What kind of surgery? As I said that some people, they will be having this intracranial pressure, increased elevated intracranial pressure because of any bleeding or because of any clot in their brain. So in that conditions we can go for this surgery if it is required. Okay. So mostly like 90% of the patients will be recovered with this surgery, and going for the surgeries will decrease the neurological deterioration. That means further progress of the disease can be controlled by going for the step of surgery. And then ketogenic diet. What do you mean by ketogenic diet? Ketogenic diet. That means ketone bodies where it will be produced in aerobic respiration when energy is produced from fats, right? So this ketogenic diet, it is nothing but low carbohydrates and high fat diet, that we call it as ketogenic diet. It also is used for weight loss in case of obese patients, right? So this is also used in this condition, and this can be used for patients who cannot take these anti-epileptic drugs. And for seizures that are not completely responsive to anti-epileptic drugs, and if there is persistent ketosis, that is increase in ketone bodies in that circulation, so in that conditions this plays a key role. And most commonly used and seems to be most beneficial in children. So some children, they'll be having this seizures from their childhood. In that conditions, they will not take this anti-epileptic drugs regularly, or they have no proper improvement with these anti-epileptic drugs. In that condition, we can go for this ketogenic diet. And then vagus nerve stimulation. Vagus nerve stimulator for the treatment of intractable partial seizures. So in that conditions, like in partial seizures, we can go for vagus nerve stimulator, which helps in the stimulation of this vagus nerve, which will further decrease this seizures like activity, and avoiding the precipitating factors. So what do we mean by precipitating factors? So the factors which will further worsen the condition, which will further progress the condition, that we call it as precipitating factors. So that should be avoided. It includes stress, sleep deprivation, that means less sleep, ingestion of excessive amount of caffeine or alcohol. So excess alcohol consumption, smoking, and caffeine consumption, lack of sleep and stress, all these also can be considered as a risk factors. So that should be avoided. So this is all about our non-pharmacological treatment. Here if you see this picture, it will be showing a ketogenic diet which is high in fat and low in carbohydrates, eggs, cheese, butter, fish, groundnuts, avocados, and nuts and dry fruits, broccoli, spinach. So these are the foods which will be more in fat and fiber and less in carbohydrates. So this is a diet that is absolutely perfect for patients who are having epilepsy, and this can be used for patients who are not responsive to anti-epileptic drugs. And now moving on to these lifestyle modifications. So proper fitness, exercise should be done. Avoidance of sleep deprivation, avoidance of alcohol, excess alcohol consumption should be there. Psychological approaches, it includes techniques to avoid seizures or reduce seizure frequency, like avoidance, relaxation, biofeedback, aversive therapy. So these are the different types of psychological approaches that can be used. And promotion of emotional well-being, like yoga can be done. And anxiety, reduction of this anxiety or depression, further some exercises or some yoga therapy should be done. And coping strategies for living with epilepsy, it includes CBT. CBT is nothing but cognitive behavioral therapy. They will be having some kind of memory issues and behavioral changes, so for that we'll be going for CBT counseling. They'll be taken for psychiatric centers for counseling, for making them more motivated to have this positive views on their life, psychotherapy, educational interventions. So it includes all these included under psychological approaches. And alternative therapy include herbal medicine, like some kind of herbs naturopathy, some that also can be used, but there is no exact proven mechanism for showing the efficacy of of these herbal medicines. It is yet to be under study. And homeopathy and others include aromatherapy. Aroma means it will be done with the help of essential oils which are having strong pungent aroma, and hypnosis, acupuncture, seizure alert dogs. So these were the things. These were the non-pharmacological and lifestyle changes for the patients who are undergoing this epilepsy. So here the calorie distribution on a ketogenic diet. So it contains 25% of the fat, 20% protein, and 5% carbohydrates. So this is a thing which this is the percentage of different types of food to follow this ketogenic diet. High fat, a bit low protein, and very less carbohydrates. That we call it as ketogenic diet. And then general approach. So what was the general approach for treatment of epilepsy? So first is it depends mainly on type of epilepsy. So there are n number of types of epilepsy. So it mainly depends on type of epilepsy and drug specific adverse effects to particular patients and their preferences. So like about 65% of patients can be maintained on single anti-epileptic drug, and some they require two dual anti-epileptic drugs. And the main reason for treatment failure in this epilepsy is non-compliance. That means if they are not taking medication properly, if they forget taking medication for 1 or 2 days, there is risk of getting another episode of seizures. So non-compliance is a major reason for treatment failure in epilepsy. And drug therapy may not be indicated in patients who have had only one seizure. That we already know that if there is two continuous seizures with a time gap of 24 hours, at that time only we'll be considering it as epilepsy and we'll be starting the patient on treatment. So if at all if the patient has experienced only one episode of seizure in his lifetime, will not be considering him as an epileptic patient and will not be giving any anti-epileptic drugs. Okay. And then what are the factors that helps in the successful withdrawal of anti-epileptic drugs? That means like in what conditions we can stop taking these anti-epileptic drugs. So first is the patient should be seizure free period for at least 2 to 4 years and complete seizure control within 1 year of onset. Within 1 year of onset there should not be any seizures, and again the patient should be seizure free for at least 2 to 4 years, and an onset of seizures after age 2 years. That means in newborn babies or infants or children in that condition, and before age 35 years, and normal EEG and neurological examination. If these were normal, then there is a chance to stop or withdraw these anti-epileptic drugs. And then when we can say that there is poor prognosis. Poor prognosis means what would be the outcome of the patient after taking medications. So when we can say that a patient is not improving, so when there is a high frequency of seizures, there is no control on the frequency and severity, and if there is combination of different types of seizures and development of abnormalities in their physical and mental functioning, so then we can say that the patient is under poor prognosis. That means the outcome of the patient is not improving. And then so here like for absence and Rolandic epilepsy, it should be seizure free period should be for 2 years, and for other types of seizures it should be at least for 4 years. That means seizure free period should be for at least 4 years completely. They should not get even one episode of seizures for 2 to 4 years. Then only we can start withdrawal of anti-epileptic drugs. That also we should not do immediately all of a sudden, only gradually decreasing the dose, and slowly we have to stop giving these anti-epileptic drugs. Okay, and then like American Academy of Neurological Guidelines, they follow according to their rules. Like seizure free period should be like 2 to 5 years, and if there is a single type of partial seizure or generalized tonic-clonic seizures, and if the neurological examination and the IQ are normal and EEG is normalized with treatment, at that conditions we can go for this, and slowly gradually we have to withdraw these anti-epileptic drugs. So here is a mechanism of action of few anti-epileptic drugs. So it includes, it mainly affects on ion channels like sodium and calcium ion channels, and augmentation of inhibitory neurotransmission. So that means increasing the CNS GABA. Inhibitory action should be increased and excitatory action should be decreased. So this can be done. And anti-epileptic drugs effective against GTC and partial seizures. They work by delaying recovery of sodium channels. So GTC and partial seizures, for that we should mainly concentrate on these ion channels. And the corticothalamic T-type C calcium channels are effective against generalized absence seizures. So here is a flowchart showing different first-line drugs, alternative drugs, and their comments. So these were the drugs. You can go through these drugs flowchart once. So if there is diagnosis of epilepsy was done, so first we have to start the patient on single anti-epileptic drug. So that we have to, how can we choose this anti-epileptic drug? Based on the seizure classification and based on the side effects, we have to choose one anti-epileptic drug, and then we have to check whether there is seizure free. If there is seizure free period, then we have to ask the patient if he is having any side effects after taking this medication. If there is no side effects, then the patient is in good quality of life. If the patient is responding to that medication but he is having side effects, then what we have to do? Either we have to decrease the anti-epileptic drugs dose. So once we have to decrease the dose, and again we have to check the seizure free period. If there is no seizure free period, then we have to ask him whether he is having any side effects. If yes, if no, then we can increase the dose and then can go to this. And if there is side effects, then we have to decrease the dose of first anti-epileptic drug and we have to add second anti-epileptic drug. Again, we have to check whether there is seizure free period. If there is seizure free period, then the patient is improving with that medication. So again, we have to continue the same medication. If there is no seizure free, again we have to ask the patient for side effects. If there is no side effects, we can increase the dose of second anti-epileptic drug, and again we have to check for drug interactions. If there were side effects, then we have to in that two, first anti-epileptic drug and second anti-epileptic drug, in that both we have to compare which is more effective, and then which is less effective, that should be withdrawn and another should be added. Okay, so this is how we'll be going. If the patient is not responding to any of these medications, then we have to consider this non-pharmacological treatment. That is, either we have to consider surgery or any use of any other anti-epileptic drugs or vagal nerve stimulation. So for that, we will be going to that step only if the patient is not responding initially to this anti-epileptic drugs. Okay, so this is the treatment algorithm for epilepsy. So here are certain drugs, a few drugs. So there are many drugs. We'll be discussing only a few drugs. It includes, okay. So first drug is carbamazepine. So when we are taking this carbamazepine, we have to be careful when the patient when we are giving it food. Why? Because it will enhance the bioavailability of the drug. So because of this reason, carbamazepine is available as controlled release or sustained release tablets. Like that it is available. So it can be given as twice dose. As like for every 12 hours we can give this. And then certain in some conditions we can even that it is formed it as capsules. We can remove this capsule and we can sprinkle this capsule granules on the food, and also we can take this. And side effect includes hyponatremia and leukopenia and rashes. So it has interactions with valproic acid. Because valproic acid increases the concentration of this metabolite of this carbamazepine, so that when these two are given, its efficacy will be increased. And generally, also some like if the patient is only on carbamazepine, we can give as a twice daily dose also can be given. And for children, they require dosing 2 to 4 times daily. That means at longer interval, like shorter intervals, for at least 4 times daily they can be given. And while calculating this, we have to give large dose at the bedtime, and dose increase can be made for every 2 to 3 weeks. Slowly, gradually we have to increase the dose. All of a sudden we should not increase the dose. So escalation of the dose should be done. And then clobazam. So when we are stopping this clobazam, it causes withdrawal syndrome. Like there will be some behavioral disorders, tremors, anxiety, dysphoria, that is excessive sweating, insomnia, again convulsion, psychosis. So these will be the withdrawal symptoms of clobazam. So when we are keeping the patient on clobazam, we should be very much careful when we are withdrawing this drug. Okay, and it will be interacting with certain oral contraceptives. So some people, they'll develop some tolerance. That means even after taking, like they'll not respond properly because of this tolerance. And then it is less effective than clonazepam for myoclonic jerks and absence seizures. And then ethosuximide, it doesn't require any loading dose. Like titration can be done over 1 to 2 weeks. That means slowly, gradually we have to titrate the dose by checking this regularly. Serum concentrations of that particular drug also we have to check. And if it is given with valproic acid, this valproic acid may inhibit this metabolism of ethosuximide. So the efficacy of this ethosuximide will be decreased when it is taken along with valproic acid. And then gabapentin. So generally it is used as second line of anti-epileptic drug, especially for partial seizures, and who did not who failed with this initial treatment at that time only will be going for gabapentin. Okay. So the bioavailability decreases with increasing doses. So that means there will be saturation till like to certain point. If we are gradually increasing the dose, the efficacy bioavailability also will be increased. But then even after we are giving more dose, the bioavailability will not improve, will be decreased. So the dose should be calculated properly. So initially we will be giving this as 300 mg at bedtime, and slowly it is increased to 300 mg morning and night. So this is how we'll be giving this gabapentin. And next, pregabalin. Pregabalin, it's a Schedule 5 control substance. It's a second line agent for patients with partial seizures who have failed this initial treatment. So as it is eliminated unchanged in the renal excretion, so dosage adjustment should be done carefully in patients in CKD patients. So as it is eliminated unchanged. So when we are treating the CKD patients, we should be very carefully monitor the dose of this pregabalin. Why? Because it may further worsen the renal dysfunction. And then levetiracetam, Levipil, generally this will be given, if you can see this, the Levipil, in most of the hospitals, we can see this is the first line of drug they will be using immediately. So it can be used as adjunctive treatment of partial seizures, and its side effects include sedation, fatigue, coordination difficulties, agitation, irritability, and lethargy. So when we are giving this levetiracetam, there is a decline in red and white blood cells. So it was found in clinical trials. So initial dose is 500 mg oral twice daily. So initially, like loading dose of 1 gram can be given, followed by 500 mg twice daily. Then the oral dose first will be started with low dose, and later on will be titrating the dose. Lamotrigine, it can be used as adjunctive therapy for both partial seizures and also as a monotherapy. So it is generally used for generalized tonic-clonic seizures, absence seizures. So for that we'll be giving this lamotrigine. So side effect includes rashes, interaction with valproic acid. So it will decrease the efficacy of lamotrigine. So because of when we are giving these two, we have to adjust the dose. And phenobarbital, it's a potent enzyme inducer. So because of that, it will interact with many drugs, and diuretics, urinary alkalizers. These will increase the amount of phenobarbital excreted renally, and cognitive impairment is a side effect. Paradoxical hyperactivity is also a side effect. And when it also undergoes interaction with ethanol, because ethanol increases its metabolism, whereas valproic acid imitated in chloramphenicol, these will decrease the metabolism of phenobarbital. So it can be dosed once daily at bedtime dosing, and because it causes sleepiness, so sedation. So in order to reduce that sedation feeling, it can be given at bedtime. It is safer to give it at bedtime. And then phenytoin, that is eptoin. Generally, it's available as eptoin brand names, and it is a first-line anti-epileptic drug for primary generalized convulsive seizures or for partial seizures. So when we are giving this phenytoin, we should not change the brand names. Why? Because a few formulations will be in one way and other formulations will be in another way. So we should be carefully monitoring the patient when we are changing the brand. And food may also show some slow absorption, but also we'll be giving it along with food. Why? Because it may cause some GI side effects. So that is the reason we'll be giving along with food. And as IM route is best avoided as absorption is erratic. Why? Because when we are giving this IM route, it will be immediately it will be absorbed. So that is the reason it should be avoided. And phosphatidylcholine, it can be given through IV route and also by intramuscular route. And it is given in the oral doses of 5 mg per kg per day and then slowly titrated upwards. And the subsequent dosage adjustments also can be done. And when we are giving this oral tablets, we have to give in the formulation as extended release preparations only. And then this is how we change the doses. So when we are giving the patient with this phenytoin, we have to check the serum phenytoin levels. If the concentration of serum phenytoin is less than 7 mcg, then the dose should be increased by 100. If it is like 7 to 12, it can be increased by 50 mg. If it is greater than 12 mcg per ml, then we have to increase the dose by 30 mg or less. And if it is greater than 50, it can exacerbate. So if the dose is, if the serum concentration of phenytoin is more, then it will exacerbate that. That means it will further worsens the condition of seizures. So it is very much important to calculate or to measure these serum phenytoin levels when we are giving this as oral formulation. So this is all about a few drugs, and there are many of drugs more to learn. So I have explained only few. We can go through the remaining. And then evaluation of therapeutic outcomes. So there should be less side effects. There should be proper outcome, like the patient should be seizure free, and social adjustment should be there, and drug interactions should be minimized. Compliance should be there. Decreased side effects should be there. And then clinical response is more important than serum drug concentration. That means the patient should be seizure free. That is a main criteria compared to serum drug concentrations. And screen periodically for psychiatric disorders. That means regularly we have to monitor the patient if he is having any other psychiatric problems, whether he is developing any other psychiatric problems like anxiety or depression. And also we have to ask the patients and caregivers to record the severity and frequency of seizures. Why? Because somebody should be always along with them in order to carefully monitor them. Like if they get any time if they get these seizures, and how long it is existing, and how different the patient is behaving, so that we can come to know which kind of seizures it is. So somebody should be always beside them, along with them, in order to monitor them and in order to take care of them. So this is all about the treatment of seizures, and thank you all. And I just want to tell you one thing, that March 26 every year is celebrated as Global Day of Epilepsy Awareness. So it's also called as Purple Day. So this is all about epilepsy. So